At first, a lot of times people are very sensitive and just need a little bit of insulin because their body's still producing some insulin. And that's
Yeah.
the gradual nature of LADA diabetes.
Right.
I did have to advocate for more insulin because I was first prescribed the long acting insulin, so like your
Okay.
once a day insulin. And
Okay.
then I was seeing though that my blood sugar was high after meals. So I did go back and I have some mealtime short acting insulin. And so I got on the multiple daily injections, which is common treatment plan there. Combination of those two kinds of insulin, and
Hmm.
then my blood sugar was in range much more of the time, but I didn't have a CGM, so I didn't have a continuous glucose monitor. And when I got that, I got a Freestyle Libre. That made like all the difference as far as the insight and what's really going on here.
Mm.
Well, I think I say this in my book, but I think a big part of success is actually not thinking about your diabetes as much and still getting the right numbers. And that's challenging, and it's not going
Yeah.
to be the same every day. But if you are constantly worried about your diabetes or constantly looking at your CGM, and yeah, I guess that would put you into micromanaging territory. So ideally, you have alarms set that you are the right levels and you respond to the alarms, but
Yeah.
otherwise, you're hopefully not thinking about it.
Welcome to the show today. Linnea May Huxford is here joining us. I'm really excited to meet you. I've recently had a chance to get my hands on your new published book, which is Success with LADA Diabetes. And I'm just going to show it off a little bit. So I'm really excited that you're here. Thank you.
Thank you, Melissa. Great to be here with you.
Yeah, yeah. And, we connected because we obviously share a very common topic, which is life with diabetes. And LADA is slightly different, and we're going to get into all of that. And your book covers it beautifully. You graciously sent me a copy ahead of time. And I'm really thankful for that. And I'm already thinking of people I can share this book with now that I've walked through it. And your LADA diagnosis, misdiagnosis, whatever that looked like for you, because I think this is an area of diabetes that there's a little confusion, or maybe
Oh,
a
there
lot of
certainly is.
confusion.
I did not expect this in a million years, right? So, I mean, I was like 31 years old and I got all the classic symptoms of diabetes. I was really thirsty, peeing all the time, and my muscles were aching. I had just gone on a hike and I thought, oh, I must just be getting old. I had no idea I had diabetes until like a few days after that trip. I was going to the bathroom all the time and like this light bulb came off of my head. Oh, this is classic symptoms. I had a relative of type 2 diabetes, so I had some awareness. But yeah, I went to my doctor and I was misdiagnosed with type 2 diabetes, which is like the most common route with LADA, or latent autoimmune diabetes. It's actually surprisingly more common than you would think. And doctor prescribed metformin, which is standard line of treatment for type 2 diabetes. And I cut back all my carbohydrates, super low carb, much more low carb than what I eat today, even. And with the metformin and the change in diet, my A1C was like 11.5 at that diagnosis. And then it went down to like, it did go under 7 initially. But then it went back up over 7 because it wasn't the right treatment. And the metformin was helping with like the insulin resistance or the
Hmm.
insulin sensitivity part of it, but it wasn't treating the root cause of the problem, which is the
Right,
same as type 1.
right,
So that's an autoimmune attack on your body. So you're
right.
yeah, you need insulin. At first, a lot of times people are very sensitive and just need a little bit of insulin because their body's still producing some insulin. And that's
Yeah.
the gradual nature of LADA diabetes.
Right, right. It is really interesting. I think back to my diagnosis, which was 44 years ago, 1982. There wasn't books like this out there for sure, right? 1982. Yes, I was 14 years old, and I remember those drastic symptoms or dramatic symptoms. When you're in it, you don't realize what it is. Again, there wasn't much education. My parents had no clue either. But you wonder, this has always been my curiosity, and I'll just kind of play devil's advocate is here. The level of when your pancreas decides to just stop producing insulin, it's different for everybody. Journey to insulin, a little less insulin, no insulin, is different for everybody, isn't it? And whether it's drastic, and that's something I'll never know. What if that was a gradual transition to my pancreas saying, I have no more for you, basically. It's so
Right.
interesting, right? Yeah.
Yeah, I also can't really say that for myself. Before this sudden like, "Oh, I'm sick with diabetes" thing, I had other problems, like I had some mood swings, yeast infections, which is like, common if you have high blood sugar.
Sure.
So I suspect that, and actually a few years before this, I did test my blood sugar because I was feeling really shaky after exercise. I thought, "Oh, maybe I got low blood sugar," and it was not low, but then again, it might have been changing quickly. But I think that
Right.
people can have like erratic blood sugar and not know it, and that could
Yeah.
be a precursor to LADA diabetes
Right.
potentially, or who knows? There's a lot of different types of diabetes that could be happening.
Right. So, what exactly, let's maybe take a step back for those of us that maybe, or some listeners here, maybe there's some listeners that have had type 1. We've always had that label of type 1 diabetes, myself included. So, maybe we're a little disconnected from what really is the difference and what does treatment look like once you got properly diagnosed, right? And you mentioned this, and this is really important. These are things that we've talked about here on the show before, is noticing, and you mentioned this in what chapter am I looking at? I'm kind of looking at your book as we're talking. Chapter 2 is basically the differences and getting the correct diagnosis. And you mentioned, and I think this is key because I'm all about testing, right? I mean, if there's tests that can determine what's happening with that endocrine organ, why aren't more doctors in tune with this? It's going to give you a correct path of treatment if you know all the facts, right?
Absolutely.
Yeah.
Yes. Yeah, and I add that to my second edition of the book because there's now screening can actually be done even before symptoms, which is
Yes.
remarkable. So, like, I have
Yeah.
no idea, but it's very possible if I had been tested for this screened as a child, even it's there's even this possibility it would have shown up then. So, yeah, it's like we're in a very good time with testing to get the right diagnosis, and that's part of the hope of my book, not only to help people with a lot of diabetes, but
Yeah.
also to inform the medical community about this that we need more screening.
That you brought that up because yes, and it's so important because again, I think they could be, it's about the medical training that they did get, and whether or not they choose to stay on track with these new ways to treat their diagnosing their patient. Everybody wins when we all know, kind of
Certainly, yeah, and that's also why I'm public
kind of
about it
knows.
now, and it's like, "Let's
Yeah,
talk about this." It's nothing to be
yeah.
ashamed of. It's, a
No.
large percentage of people are dealing with diabetes, whether it's type 1 or type 2, LADA or something else.
Mm-hmm.
There's even MODY, there's some other genetic kinds. So,
Right.
yeah, having that differential and figuring out the type of diabetes, it's incredibly important. It's a misconception that, like, type 1 is only in children. That's not even the case at all. I think if you look at actual numbers, it's more people are diagnosed as adults.
All ages, yeah, it really is. It seems like an epidemic right now. All the women that are coming to me, all ages, again, midlife, all the things that are, and again, we don't necessarily know what their cause was or what directed their body to basically attack those islet cells. So let's look at the testing. So how do we get a correct diagnosis? And of course, we're hoping some doctors are maybe listening today too.
Right, right. I
Here's
can't say
some
it's like
tips.
everybody's unique in this, right? But there
Yeah.
is the autoantibody panel. So basically checking to see if your body is producing antibodies that would signal that your body is attacking the beta cells in the pancreas. Now, the only part of your body that makes insulin. So there's at least four, probably more than four, but there's a panel of antibodies to test. GAD65 is the most common one
Is it?
that's
Okay.
present with LADA. But yeah, that panel will, that in many cases, that would give the diagnosis of it not being type 2.
Okay. Kinda
And then
rule that
there's,
out, yeah.
yeah, to rule out type 2. And then the C-peptide test tells you whether how much insulin your body's making. And it depends where you are in your diabetes on how to interpret those results. But in general, people who have an autoimmune condition, there's less C-peptide because your body's making less insulin.
Right, basically, yeah. I mean, yeah, I love the fact that there are some clear tests that we can take to determine, to help everybody in this situation. So at what point, they obviously ran these tests. Is this something you had to advocate for? Or were you learning as you went just like the doctors were?
I got a referral to an endocrinologist, and once that happened, she did the right tests. So I didn't have to advocate for the test specifically from the endocrinologist. And I think in general, endocrinologists are likely to do these tests compared to a primary physician, general practitioner, which is who I
Yeah,
went to first. And that's understandable. I did have to advocate for more insulin because I was first prescribed the long-acting insulin, so like your
okay,
once a day insulin, and
okay,
then I was seeing though that my blood sugar was high after meals. So I did go back and I have some mealtime short-acting insulin. And so I got on the multiple daily injections which is common treatment plan there. A combination of those 2 kinds of insulin, and
Mhm.
then my blood sugar was in range much more of the time, but I didn't have a CGM, so I didn't have a continuous glucose monitor, and when I got that, I got a Freestyle Libre. That made, like, all the difference as far as the insight and what's really going on here.
Mm.
It took away some of the anxiety I was having, like, "Oh, is this low blood sugar? Because after I eat a meal,
Yeah.
did I get too much insulin for that meal? Am I gonna
Yeah.
go low?" And I have to prick my finger and do a blood test, and you see that one moment in time. So a continuous
Yeah.
glucose monitor, which is now it's like you can even get one over the counter if you don't have
Yeah.
diabetes or, well, if you don't use insulin, the over the counter CGMs are available. So
Yeah.
that's what, like, oh, now it's like that sort of was the pathway to, oh, I want an insulin pump because
Okay.
I had to do more injections because I saw that I had high blood sugar, and
Mhm.
then I didn't want to do 6 injections a day or more than
Sure.
that even if I
Sure.
have
Sure.
snacks, dessert, how that goes.
Yeah. Yeah. So at this point, when did this all begin for you as far as your age and how many years ago was this LADA
So I was
diet?
31, I'm 44 now.
Okay.
So,
Okay.
yeah, about 13
You've been
years.
in the game for about 13 years. Okay. So are you still technically, test wise, are you still in the LADA phase? We'll call it a phase stage.
I consider myself type 1. I actually need to go get another C-peptide test and see is my body making any insulin itself, and that's on my list. Please check me. That's
Yeah.
not something that is my doctor. It's not a routine test, so I am very curious. I have read that if you can prolong the time where your body is still making some insulin, it's better for your long-term health, which is why actually getting the right diagnosis early and having starting insulin earlier can help you protect your own ability to make insulin is what I've been hearing. So,
Ah, that's very
yeah.
interesting. Yes. Wow. So right now you're 13 years and you are on a pump. We had a Bernita Rose. I remember her. She was on the show in my first season. And this is really our first introduction with LADA. And she taught me a lot as well. And again, everybody's story and transition is different. But it's interesting because I'm kind of like a black and white person when it comes to things. And maybe you can agree with this that would it be, and I guess you haven't had a chance to experience this. And I guess the C peptide is going to confirm this for you. But I always thought when she was explaining the variables of, yeah, my pancreas is helping me a little bit. I've got to fill it in with insulin over here. To me, that would be a lot more confusing than just being, okay, I'm in charge, right? Because you've got this other factor that's still affecting the outcome. So I admire what you're able to juggle and to figure. And it reminds me of perimenopause is what it reminds me of, because now we know so much more about how the other hormones impact how insulin is working or what you need, what you don't need, depending on the time in the month and all of that. So what's your thoughts about that? Not
Well,
that
it
you have any
is
control over it, but it's just such an interesting way to
right.
consider it. Yeah.
Right. Well, there's a whole bunch of hormones. Yeah, perimenopause is a great it's very similar, I would say. So I guess you're saying like anything that's like, oh, this other variable that is like, okay, I need less insulin today and more the next day, which is the reality of what I experience sometimes. And that is probably for me, yeah, beginning of perimenopause, hormone fluctuations. But there's also stress hormones that also can cause a really significant impact because those are counter regulatory. They work against the action of insulin. So yeah, you have the female hormones, you have the stress hormones, you have
Yeah.
growth hormones if you're like still growing as a
Right.
teenager.
Right.
So yeah, I mean, that's why I really think an insulin pump with the automation is so helpful because it can cut back on the insulin automatically.
Right.
Whereas if you're doing the long acting insulin, some of those long acting insulins are very long, right? The time
Yeah.
span is like a few days. So if you suddenly need less insulin, you're going to start
Yeah.
going low unless
Right.
you compensate by eating. And you don't really want to eat. You don't want to really eat because you're going low if you can
Right.
avoid it, right? Because you don't want to gain the weight. So,
Yeah.
I mean, yes, treat the low with something that is sugar and not fat, but yeah, it's extremely challenging, and I think
Yeah.
women in particular, I think, have a lot of this extra challenge because of all the hormones, so
You just nailed it. And then nobody slapped being a woman on there too.
not
This
at
is not
all.
a dig to the men because, there's definitely some men that listen here on the show too. So again, it's just about awareness and understanding how the body works and how insulin is definitely our friend. You mentioned that you have a chapter in the book embracing insulin. I love this too. And this can apply to all of us. It really can. It's really understanding the value of insulin, not fearing it, embracing it. I love that. So tell us a little bit about why you wrote that chapter.
Well, it was really a lot of relief to actually get something that worked. So insulin worked to manage my
Yeah.
diabetes. And it's also like, thank goodness insulin exists and I'm not going to die of this, which 100 years ago, remarkably, it was like a death sentence. So, I mean, yay. Insulin is so important. And so I'm wearing Insulin for All t-shirt. It's amazing today, actually, that there's some parts of the world where people have trouble with getting access to insulin, but yet
Yeah.
embracing insulin. And I know that some people, insulin's very scary. Maybe they have somebody in their family that needed insulin and they were in very bad health. So they think that the insulin maybe was part of the cause, but that's really
Right.
not the case at all.
Right.
So embracing insulin, and it's also, I know it's intimidating at first if you need insulin shots, like, oh, you got to figure out how to give yourself an insulin shot, which is like
Yeah.
something you've probably never done before, have any
Yeah.
idea about. And
Yeah.
so, there's a lot of challenges to that, but insulin is, then you can get your blood sugar in a more manageable range, and it takes a lot of time to figure it out because the dosing is tricky. A lot of medications, you take a little bit too much, it's no big deal, but with insulin, that's going to be a problem.
Mm-hmm.
Yeah.
Yeah, I totally agree. I think, I mentioned relationship with our diabetes, but insulin is a big part of that as well. Whether or not we feel that there's a stigma to have to take, I mean, medicines in general, hormones in general, there's a stigma around you needing something, but we can't survive without insulin. It is a needed hormone that interacts with so many other parts of the body too. So it's really cool. I really love this chapter, and definitely something I think everybody needs to take a look at, just to, again, just kind of get their mindset around the importance of it and to have a good relationship with it.
It's actually becoming more mainstream as people are talking about insulin resistance and how that can be tied to illness.
Yeah.
Like, I think it's getting, more knowledge about this because everybody needs insulin, right? Just like
Yeah,
most people, their body produces it themselves.
absolutely. Again, awareness, right? Education. And this is the reason books like this coming from people like you who have experienced it and have studied it is so important for all of us to get a hold of and to refer to. You know what I love about your book too is that it's a reference guide. And this is my goal with the book I have coming out too, Highs, Lows, and Hormones, is it not every chapter is going to speak to you right now, but just being able to go back and say, oh, let me go see what um, this book
Right.
had to say about that topic, because, and I think that's another thing too. I think we can feel like we can get bogged down with a lot of information and we don't really need to. We can just take what we need when we need it, apply it and utilize it when we need it. So that's really helpful. Yeah.
Definitely, for sure. Yeah, and
Yeah.
that was the challenge of like, well, some people reading the book, they may not need insulin first because there is that gradual progression.
Right.
So do I talk about it
Right.
or not early on? I
Right.
decided to lean into talking about it earlier, but like
Yeah.
skip over the parts that don't apply to you yet. And
Yeah.
yeah, it's a reference book.
A reference book for sure. So talk about sugar surfing and
Sugar surfing, yeah,
yeah.
dynamic management
Tell
of
me
your
about
blood
that.
sugar. So that's coined by Dr. Stephen Ponder, endocrinologist, diabetes educator. It's the concept of essentially that you use a CGM, a continuous glucose monitor, and then you do insulin correction boluses and eat food at the right time, essentially. So if you have high blood sugar and you eat something with carbohydrates, your blood sugar is only going to go higher. So you need to wait for the insulin to lower your blood sugar into a more normal range and then eat. And so he has in his book Sugar Surfing is terrific. And he endorsed my book, and which is like, yay, but I reference it many times and I learned from it as well, like how to do this. And it's, managing type 1 diabetes with a CGM, a continuous glucose monitor, and then using like either insulin pen, or insulin pump, whichever method there. And with many insulin pumps today, they have a algorithm that will automatically give you the insulin dosage and it will change it for you.
Mhm.
A lot of them have some shortcomings there because, like, for my example, because of hormones, if I need more insulin one day compared to the previous day, maybe I need even 20 to 30% more. And
Yeah.
this happens like several times out of the month at
Yeah.
least.
Absolutely.
Yeah, so that insulin pump on its auto mode, I use the Mini Med 7 AG insulin pump, but other pumps have similar concepts here where you have like an automatic mode that's going to base it on the previous days. And if the next day is not like yesterday, then I put my pump into manual mode and I have it programmed with basal rates. And then I do the insulin corrections and I give myself more insulin for the
Yeah.
meal. And that way, if I left it in smart guard, which is the auto mode, and if I did that, I'll give it more insulin for my meal, it would actually cut back on the autumn of the background insulin
Get
because
it.
it would be like, oh no, she's going to go low.
Yeah,
No,
I
I'm
get
not
it.
going to go low. I need more insulin today. So yeah, you have to be smarter than your pump sometimes, right? I mean,
Yes.
yeah.
I love that. There's the quote of the day. Yes, yes. I enjoy manual mode on the Omnipod 5, for those same sort of reasons, because I just choose to have a little tighter control, and it's just like those pauses in insulin when we know better about what we're doing or what we need. So what's the difference? What do you think the difference between managing diabetes and micromanaging it is? This
Oh, that's
is
a good,
yeah.
yeah, micromanaging it.
Yeah.
Well, I say this in my book, but I think a big part of success is actually not thinking about your diabetes as much and still getting the right numbers. And that's challenging, and it's not going
Yeah.
to be the same every day. But if you are constantly worried about your diabetes or constantly looking at your CGM, and yeah, I guess that would put you into micromanaging territory. So ideally, you have alarms set that you are the right levels and you respond to the alarms, but
Yeah.
otherwise, you're hopefully not thinking about it. And that takes a lot of, well, it helps to have really great technology to get to that point. But yes, it's if you're thinking about diabetes all the time, there's like more to life than diabetes. So
Yeah.
and also it's not like the end of the world if you go high for a little while, right?
That's right.
It's not perfectly acceptable to get out of range a bit. In fact, they push like, oh, 70% in range is good enough. Now I get much better than 70% most days,
Yeah.
but it's like the mental health piece is
Yeah.
important. So, and if you're stressed out about it, then that's going to work against you because of those
Yeah.
stress hormones. So,
You are right.
yeah.
Yeah, I agree with everything you say. It is so true. Yeah, because again, we have to look at the big picture. And this is something too I think is real important. And again, we've talked about this on the show with other guests and some of my solo episodes is how important, the A1C is kind of our scorecard. But, looking at really what's happening, the hours of the day, right? So I think it's more important. Personally, this is what I try to do. And I'd love that you said that, if we happen to go up to 180 or 200, well, just wait, be patient, and you step away from the data. I know that's something I'm learning more about is to not hover over the CGM because you just got to let your body let it do its thing. It may take a little longer than what we want it to, but just to not, again, micromanage it, just kind of let it go. It takes practice doing that. And some days are easier than others, right?
Certainly, certainly.
Right.
Those are
Yeah.
like the anti patterns I call out in my book, like because if you hover, just saying you're hovering over it, then you're likely, oh, I want to give myself more insulin, right? Because you want to get to go
Yeah.
lower. But if you
Yeah.
do that, you might end up low, right? So,
Right. It's going to create another problem. Yes.
right.
Yes. We just got to step back again, drink the water, go out and take a walk, do something else, just get our mind off of it. To just, again, let your body, let the insulin, and just like what you said, the cortisol is not going to help the situation. So being stressed or over micromanaging, if we're micromanaging, then it turns around and it almost manages us, doesn't it? Rather than us just letting the system and the insulin do its work.
Right. Diabetes burnout is a real thing that people can fall into. And then sometimes people, because they're so burnt out, they stop their insulin, which is like the worst possible thing you could do. So
Yeah.
you don't want to get burnt out. That's very, very, very important.
Hmm.
Mental health first.
Yeah. You mentioned too, well, you have a whole chapter on mental health and just, so what do you think, or what do you wish more people understood about the emotional load of living with LADA or type 1?
Yeah, I think that it's a lot to manage and that it gets better with time, right? Like anything, practice and experience. If you have people, your family probably really care about you, but if they don't add pressure on, right? Be prepared to help them out, have something to help them if they get low blood sugar. Criticizing what somebody eats or something, like that does not help at all. So,
Yeah, yeah.
yeah.
I think it kind of goes back to we all have friends that think, and I've said this a couple times that maybe sometimes among our friend circle and family, we kind of make it look easy.
Yeah,
You know
yeah.
what I mean? It's like, well, we're just doing it. It's all kind of happening. We might pull our pump out, but they really don't understand why or They just don't understand. So maybe we need to cry more. I don't know. So that there's more of a connection with really how tough this is. But they really don't. There's lots of parts of diabetes that unless you live with it, people just will probably never get.
Yeah, yeah, it's one that reminds me of an experience. If I'm eating out at a restaurant, I don't eat dessert, but sometimes I'm in a situation where like, everybody gets dessert. It's like a fancy meal, and that's the
Yeah.
last course. You all get dessert, so I
Yeah.
give my dessert away. Which last time I did this, that got into discussion about like, well, why? And well, it depends how good I want my numbers to be, and like, do I want to be stressed out after this meal, right? And
Right.
but yeah, and then then the conversation was like, oh, well, I've never eaten this dessert before. I have no idea how much sugar is in it or anything like that. And I'm like, oh, well, maybe you can take a picture of it and then AI can tell you how much sugar is in it. And I'm like, well, yeah, okay, but you still have to bolus before you eat this big thing of
Right.
sugar. And like, so I would have had a plan 10 minutes ago and then
Yeah.
and then wait 10 minutes before I eat this thing that's sitting in
Yeah.
front of me. And by then everybody else has already eaten their dessert. So anyway,
That's hilarious. That is so true. So when it's all said and done, how important is that dessert, right? I'm with you 100%. There are some things that I will choose to dose for. And it just like you, there's just certain situations, how you're feeling, whatever, and that's
right.
okay. But to give yourself permission and say, I know my body's just not really good today, and really good is probably not the right term, but I just kind of know my trends today and I don't want to add another variable into it.
Yeah.
But we know why we do and why we don't. And hopefully, I try to think ahead, trying to predict the best I can and just try to influence how I'm going to feel, whether it's bedtime or 2 in the morning or whatever. So,
Yeah, to put it in context, I absolutely eat dessert sometimes and stuff like that. And if I'm going to, and I can do a bigger bolus for the meal, and then probably it'll work out much easier. Yes, it's personal decision about it and the circumstances and your choice about what you want to eat and not eat, and nobody's else's choice, right? It's
no, there
up
you
to you.
go. There you go. Another thing there's a section at the very end of the mental health chapter and I love this header, it's how to give yourself great advice. And this kind of pairs into what we're just talking about. It's like, okay, you're going to speak to yourself as to where I'm at, where I am, where I'm at with my blood sugar or whatever this day is looking and feeling like. So giving yourself great advice. I love that. It's that self-talk. That's
Certainly,
something
yeah.
that
So it's you. You can probably figure out the advice for yourself. Yes, yourself more than anybody else does.
yeah. And then, another thing too is maybe to flip that. So if you're not sure, how would you answer this for somebody you knew, right?
Yeah.
I'm not a psychologist, but I've heard that method to use before. So switch it. What would you advise your friend? What advice would you give to somebody else? Same
You
sort
must
of
have read that
thing.
section because that's literally what it wrote, what it says.
Is it? Yeah. It is so true. I mean,
Yes.
it's perfect for this disease. It really is.
Yeah.
Yeah.
Yes.
And chances are we've been through um, this situation with our blood sugar or life with diabetes, whether it's the mental load or just the atmosphere that we're in or whatever. And it's to reflect that to what we did before. How did that go? I'm all about reflecting and trying to remember. Sometimes we forget it, but we have to remember the previous circumstance and how it ended up and then learning from that and maybe, what can I do differently? But to me, I think that's the best way to give ourselves the best advice.
It
Yeah.
really is.
Yeah. So for women who feel like their blood sugars are unpredictable in their body, and this is something I hear a lot in our community, is no longer making sense. What would you want her to hear?
You mean like during midlife and perimenopause?
I think it really, the reason I'm asking this is that especially when there's a diagnosis that maybe you yourself are not sure. There is that stigma. I've heard women, specifically women in the community, talk about how there's a lot of attention on type 1, people living with type 1 diabetes, as far as the terminology. And it's kind of like, what's a label? It's a diagnosis. It's a disease name. And then LADA kind of gets pushed out. They don't necessarily feel included. And in some cases, they can feel excluded from the conversation. And that's something I'm very sensitive to, too. It's something that I've referred to in my book is understanding that it's insulin dependent diabetes that I want this podcast in my book and, all that we do to kind of refer to. But that's something I had to learn because I had to kind of hear from other women that were experiencing that. And I remember getting that feedback from someone. And it woke me up to the fact that, yeah, I don't want to exclude anybody just based on the type 1 title.
Right, I love the
Yeah.
fact that you include LADA in your book, yes,
Yes.
I was so appreciative of that because, yes, it's been a worry. I have not had type 1 diabetes since I was a child, right? So many people of my age, if they have type 1, they've had it for more years than me,
Yeah.
and although I guess that may just be a misperception since it can be diagnosed as an adult,
Mm.
but yeah, I think a lot of people with LADA ultimately just end up saying they have type 1 once they get the right treatment, and it's probably easier from a treatment standpoint, and that I do say that in my book, like, okay, it's fine to call yourself somebody with type 1 diabetes. It is treatment is the same. And interestingly, though, I was looking at the numbers lately, and there's probably more people with LADA than type 1. If you look at the
Interesting.
percentages of misdiagnosis, so they say that it depends 10 to 20% of people who are diagnosed with type 2 initially actually have LADA. There's like 530 million people of type 2 worldwide. So you're looking at like 53 million people with a 10%, a conservative number, like 53 million people with LADA. So like this is not a rare condition at all. It's just not well understood. It's not publicized enough.
Yeah.
But
Yeah.
it's not uncommon. So yeah, I mean, it's the LADA diagnosis, right? I think it's better to call it a subtype of type 1, and they do call it type 1.5, but if you look at
Right.
what the root cause is, it's really more like a subtype of type 1. And yeah, I mean, and as a community, I think we should be inclusive with everybody who has diabetes, no
Yeah.
matter what kind of diabetes, right?
Yeah.
I mean,
Yeah.
would we want to exclude people at all? I mean, yes,
Right.
there are differences, but we can help everybody out.
Amen to that. Yeah, absolutely. It really speak to everybody and everybody, like we say, whether it's the, day-to-day management, the emotional, the relationships that we're having to encounter or that we choose to encounter with this disease. I think it is another points too is another thing I've heard is that the doctor's office, sometimes it starts at the doctor's office where they're a little confused as to really what your diagnosis is. So they might, I don't know, if some people, I guess some of them might even get the type 2 diagnosis like you did and still feel a little confused and still not feel well. So you feel like, well, okay, you're treating me for this disease, but I'm not feeling like my old self again. So clearly there's been something missed here. But I really, not only our community, but the medical environment, that doctor's office, there really needs to be an understanding. And I don't know, I keep going back to insulin dependent because when it's all said and done, that's really what we all share,
Right.
right? Then for insulin at some point in time and number and level and all that. So it's just a matter of time. Yeah.
Right, right. My medical record from the beginning, once I got the LADA diagnosis, it said treated as type 1. So that was sort of how they dealt with it.
Good.
But yeah, I also hear from people that say they don't feel like their regular self. And particularly some people say that they feel really tired and fatigued. And, I do wonder maybe if there's some of those people who have like another autoimmune condition, like a thyroid autoimmune
Right.
condition. And it's not,
Right.
maybe that's not diagnosed
That's
because
so true.
once you get your blood sugar in a normal range, I would not think you would be tired. I mean, you could
Right.
be tired from the stress of managing this chronic condition, but I
Right.
mean, at a certain point, I would expect that having your blood sugar in normal range, you would not be tired any longer. So if you're
Yes.
tired, maybe there's something else going on.
Yes, I agree with that for sure. Yeah. Again, it really about running those tests. I think we started this conversation talking about how important it is to get that data just to either confirm or rule out. But thyroid is an example. Yeah, there's a lot of connections with that for sure. Or just things like our vitamin and mineral deficiencies.
Right. Yeah.
B12, as we're getting older in our 40s, drops for women. Our D3 drops. Those are two things that really influence our energy, more so for some people than others, but some are more sensitive to that. So yeah, it's all about getting that data for sure. Yeah.
Yeah. I'd love to learn more about that. That's an area I have not researched. Yeah. The
Yeah.
minerals and the vitamins and stuff. Yeah. That
Mhm.
totally. More about that.
Yeah, yeah. And again, yeah, just another example of things that some doctors may not know fully about, but, to look at definitely trusted resources and just to have some sort of a starting point as to what to search for. Again, these tests are covered by insurance. This is not unusual things to be looking at. It's just knowing what to look for and being able to kind of, again, confirm or rule out, right?
Right,
Yeah,
right.
we want to feel good. We want to feel good for sure. Yeah. So you are mid-40s. And so how is this time of life? I know you're still confirming, talk about confirming C-peptide levels. You're obviously managing type 1 diabetes, but how has the other hormones, the reproductive female hormones, how have they been behaving for you, if you don't mind sharing?
Oh, yeah. Well, I mean, the biggest thing is that usually, like, when you have regular cycles, I was able to track, okay, at the beginning of my cycle, I am much more insulin sensitive. So I need less insulin. And then at the end of my cycle, I need much more insulin because I am more insulin resistant. And that's the progesterone, right? The
Yeah.
increase there. But suddenly, if your cycles are not regular, then how do you?
Right.
So, I mean, I am still figuring that out, but essentially, I mean, the biggest thing I've done is now basically every morning I've been putting my pump in manual mode because in general in the morning I need more insulin anyway. And I'm like, oh, if I put it in manual mode, I actually get better blood sugar numbers. And then depending on how the day goes, from that I can sort of see because that's like in manual mode, it gives me the same amount of insulin, essentially like the basal's
Uh-huh.
programmed at
Uh-huh.
a set rate.
Yeah.
So then I can sort of see as the day progresses, where am I at? And that can be a hint like, oh, my blood sugar is higher than it would normally be at this set rate. Okay, so it must be one of those days where I have more
Yeah.
progesterone going on and I must need more insulin, right?
Yeah.
I'm trying to exercise more as well because exercise really helps with insulin sensitivity and
It
stuff.
sure does. Yes. Yes. That fact.
Yes, that was something I
Yes.
noticed early on. It's like, oh, I was walking like just a 20-minute walk around my neighborhood and like just if I didn't do that, that was enough to see a difference. And I was
It doesn't it?
surprised.
Yeah, it's amazing how it'll just move and kind of, I guess, force the body to kind of uptake the glucose. So yeah, and move the insulin. Yeah. Yeah. And our body meant to move. So there's another point in that.
Yeah, yeah.
Just that we know, and it's a good reminder for sure. As we close our conversation today, I know, you wrote this book. Again, it is Success with LADA Diabetes. And your subtitle is, and I love this, Achieving Optimal Health with Diet, Exercise, and Insulin. It's just a nice way to kind of bring it all together. I just love how you brought all this into a resource that clearly explains from your own personal view as well, and then clinical. I know there's a lot of data and research that you put into this book. What's your hopes now that it's about to get on the store shelves as we're recording today? Will be May 16th was your official publish day. So it is available for purchase. So tell the listeners really, what they're hoping that this book is going to assist with them.
Well, well, yes, so diet, exercise, and insulin, those 3 things combined. It's not like you do diet and exercise in the beginning and then later on you need insulin. I
Yeah,
mean, you may not need insulin initially because of the gradual nature, but it's really about all 3 things combined. So that's the focus there, and also the mental health aspect of it, and also like the book, I put rainbows on the front cover, right? So it's like this is not this end of the world. This is like a new beginning for you. It is a challenge. It's definitely challenging. I said that it was an opportunity for personal transformation, and I know that's a really big claim here. But if
sure.
you can do this hard thing, you're going to learn about yourself. You're going to achieve something that's going to be really good for your long-term health, and you don't know what other things will come of that. The opportunities or the possibilities here are really endless. Whether
Yeah,
it's like you start doing more home-cooked meals, and your
right.
family eats healthier as well, or they learn to cook or something like that,
Yeah,
or you have a garden, or maybe you exercise more and that leads to something really
yeah,
amazing.
yeah,
Maybe you needed to change your career even because this is expensive and you need health insurance. I
yeah,
mean, who knows what your personal situation is, but yeah, it's not the end of the world. It's something that you can totally manage and be healthy with, and
yeah.
that's the goal
I love that.
to show you
Yes.
how that is possible.
Yeah, yeah, and evidence that it can happen, and giving examples, clear direction, and inspiration. Yeah, it's really good. We're all handed challenges, guaranteed, right?
Yep.
That's what life is. That's what doing life is. And I think the community resources and getting to know people that are living this as well, that really does make a world of difference as well. So. You have any closing thoughts before we say goodbye today, Linnea May?
Just please share the book with your doctor, like anybody that spread the word and learn about this because we really need to end the misdiagnosis
Yeah.
and get more on the right path. So that's, the more you can do to let people know about LADA, that's just awesome.
Yeah, yeah. Well, good again. And share with our listeners how they can stay in touch with you.
A YouTube channel, Linnea May Huxford, a lot of stuff there. I also have two websites that need to be redesigned, but anyway, LADA-diabetes.com and also insulinpumplife.com. And the book is on Amazon, probably all over the world. So yeah,
Yeah.
wherever you are at, you should be able to
Awesome.
find it.
I appreciate that. And yes, we'll be sure to link all that right here in the show notes to make it easy. If this touched you and educated you on some level or all levels, please share the show, reach out and do that. That's how the show grows and that's how we can reach more women. And that is why we get up every day. One of the reasons why we get up every day is to serve and to help. So everybody have a beautiful day and we'll be back in here next time.
Thank you, Melissa.
You're welcome.